For attending tonight's special meeting for HASC, discussing the reprocurement of community services contracts. Can I just take any apologies for absence first, please? Councillor Galvin.
Councillor Clark, Chair.
Thank you, Councillor Galvin. Is there any urgent matters by reason of special circumstances? No urgent matters from me as Chair. Any disclosable pecuniary interests or other significant interests and whipping at all this evening? None at all. Fantastic. Members, I thought it'd be really helpful, first of all, before we go to the item, just to go to Michael. Michael's just going to give you an overview of what a substantial variation is. I know you've all read your papers, you've all looked at it very clearly. I just feel it'd be really helpful for Michael to spell out to members exactly what our role is with a substantial variation. Is that okay? Over to you, Michael.
Okay. Thanks, Chair. So regulations require relevant NHS bodies and health service providers to consult HASC about any proposal which they have under consideration for a substantial development or variation in the provision of health services in Medway. Now, the term under consideration is not defined and depends on the facts, but a development or variation is unlikely to be held to be under consideration until a proposal has been developed. Likewise, the phrases substantial development and substantial variation are also not defined in the legislation. However, guidance on this states that the key feature of a substantial development or variation in a health service is that there is a major impact experienced by service users, carers and/or the public. And it's not about whether the outcome of the change is considered to be positive or negative. Many councils have developed joint protocols with the NHS about how to reach a view as to whether or not a proposal constitutes a substantial development or variation. Now, such a protocol was agreed with the clinical commissioning group which preceded the ICB, and this includes a checklist aimed at helping to reach a view about whether a proposed development or variation is substantial. Now, the checklist was completed by colleagues in the ICB, and this can be found in Appendix 2 to the report with your papers tonight. And members will note that the ICB have concluded the proposals are not, in their view, a substantial change. So in terms of to make a decision as to whether to proceed with the proposals, you would then have the power to make comments on the proposals and may refer the proposals to the Secretary of State for consideration in certain circumstances. However, there's a very high bar for that. Or alternatively, could decide it's not a substantial variation at this point, and you could then decide to have no further involvement, or you could decide to still scrutinise the proposed changes anyway, using your general powers that you have for health scrutiny. So I hope that summarises the position. Thank you.
Thank you very much, Michael. Thank you. Welcome, Lee and Mark. Can I just say to you both, obviously you've got a very good scrutiny committee here in Medway. I'm sure Mark may have told you that from before. I know you will get some intense questioning because there is some things missing from the papers that members have asked for, so you will get some questions on that. But first of all, it's just for clarity purposes. I know we asked for it to be taken out of the paper, but it's not children's services in Medway, is it, that this is? Could you just clarify that for our...
There you go. That better? Yeah, there we go. Thank you. So Children's Services in Medway, we've got an integrated team between NHS and local authority, really good working relationships, really good model of how we keep that model of care active and along with the national best guidance. So that is not included in the contract that we're putting forward today.
Thank you, Lee. So if you can just do a quick overview of the report. Members, those of you that attended the special briefing online, thank you very much for that. And I know many of you have also looked at the recording that had a different committee that evening as well, so thank you. But for tonight's purposes, we still have to have an overview of the report, please, Lee, and also you can touch on the substantial variation, why you may not think it is one as well at some point during your presentation. Thank you. Over to you, Lee.
Thank you. And first of all, thank you for doing this special meeting for us. We really do appreciate, and it's extra time for you, so we do thank you for that. This is really important to us. We know from coming out of COVID that the NHS had a backlog of contracts, so we had to suspend contract management and reprocurement of contracts during COVID because of the things we were concentrating on, and I'm sure you can all imagine we were a little bit busy in that time. So we've got a backlog of contracts that are trying to be negotiated now. This one is our main out-of-hospital contract, and it's for Kent adults, Medway adults. It's for Kent children's, but not, as we said earlier, for Medway children's. We do want to try and do this contract in a bit of a different way. The present specifications that we've got around the different pathways in the contracts, that's the clinical pathways, are pretty old. So community contracts have been built probably over the last 10 years. Different models of care as we've learnt about moving services out of acute care, so out of hospital into the communities, integrating primary care more, integrating community nursing more. Those models have developed, and we can do a lot more for patients and citizens in the community than we used to years ago. So our present models of care may not be at that level of best practice, and most of the pathways in adults and children's have got best practice now that's nationally driven. So what we want to do with this contract is roll over the present specifications from the 1st of April next year, so that's 1st of April 24, and that's for all services, and then spend a year doing the transformation work. And the reason we want to do that is there's a lot of public engagement that we want to do, and especially looking at how we design the models of care that really get embedded locally based on the national best practice. So all those 9 pathways in adults and the 7 pathways in children's for Kent, we want to make sure that they are built with that local interpretation, so the best out of the services that we're doing locally. So national models setting the strategy, but building them locally. In the rollover of the contracts, it is a 8-year contract, so it's a 5 and 3 year. We have looked at transition periods, and transition periods would be part of that year of transformation. We also want to really work on skill development. So we know that part of the new models of care are developing a wider, broad group of staff who can do different clinical things. So we have qualified staff and we have trained staff. We really want to work on that. We know that the old model of primary care, where you had a GPC in all patients, is probably not the model for the future. So it really does have to be those integration between primary care, secondary care, linking in those community models of care. So that skill development centre that we want to set up is all about how do we retain and recruit staff into local areas, and how do we use a skill escalator to make sure that people have got a worthwhile job. They're not just doing the tasks every day, they've got development in their work. And that's really important to us, and I'm sure that's really important to you in the local area. The third part of the contract is the underpinning IT. So we know that the infrastructure for IT, we have that in pockets. We want that to spread across the models of care so we get seamless services between acute, between primary, and patients can move without the duplication. We've had lots of feedback about patients telling their story multiple times, and that's part of that transformation work. We want to get away from those handover times, potentially lost clinical information, so patients and families tell their stories once, and that continues through the journey. So this contract really is about rolling forward for that first year from the 1st of April, and then we go into the year of transformation. At the end of the year of transformation, we'll redo all the specifications, so we'll lock in the specifications, and that's what people will be held to account from that year going forward. Been talking all day. I think the main bit we wanted to get across is this is a different way of doing contracting, and the ICB has been running around 9 months. We recognise that we've got to do some things differently to get the transformation that we need. Traditional contract management probably would not get us the transformation that we want to do with our providers. This is about linking people together that may not have linked in the way we want them to do in the future. We also know that we've got to build services that are agile and also can be scaled up. So we know that population management coming through for older people in the next 2 years, we've got a real wave of older people coming through. We've also got the growing population for children, so we want to make sure that's part of the new models of care. They're scalable, they're agile, they can keep adapting to what our patients need. Just on the significant variation, we don't think it's a significant variation. There's a main reason for that is we will roll over the present services into next year, and then we go into the year of transformation. We want to involve both HASC and HOSC in that public consultation that we'll be doing with specific groups. For this particular contract, because there's different pathways of care, it's not just about a community service as in traditional old community nursing. There's lots of different pathways of care in this. We're going to have to do consultation in different ways, and there'll be different groups that want to be involved in those redesign of those pathways. So it's not going to be one consultation, it'll be lots of different consultations along the pathways. So we don't think it's a significant variation because we're not letting a new specification, we're going into that model of care change for that first year. Thank you, Dan.
Thank you, Lee. Members? Councillor Wiley.
Thank you, Chairman. First, I'm very, very disappointed in the report. You've just said you've been looking at this for 9 months. This is the main out-of-hospital contracts. We had meetings on 2nd of August. This report was postponed because you couldn't or didn't have time to write it. And you've said in, 3 minutes, much more detail than is in this report. It seems unbelievable to me that I'm trying to be polite because I feel insulted. You say you need more time for a full and proper report, and as I say, 4 pages, and it simply is certainly anything but a full and proper report. Can you tell me what's in this paper that you didn't know about on the 2nd of August, let alone our last HASC meeting? It just seems, insulting to the committee. I'll stop there and then I'll come back with some more questions.
Oh, thank you. And I'm really sorry, I can't see your nameplate. So normally I'd use your name. So I'm really sorry, I can't see them because the lights are shining on them. So sorry about that.
I'm David.
David, hi David. So I apologise if that's how it feels. We've done quite a lot of work. We've got a number of contracts that we're trying to work through because of the COVID backlog. It's hundreds of contracts, as you know, just as the council has hundreds of contracts that they have to do. What we didn't want to do is rush this into doing a traditional contract management change, and that's why it's taken us a long time. We've had to take legal advice. We've been working with other ICBs around the country to see if anybody else has done this model. So there's been some really detailed work around the present specifications and how we'd work through what would be the strategy around those models of care coming forward. That's taken us a long time to do. When I said 9 months, the ICB's been running for 9 to 10 months. The actual getting to this contract, we've only been working on it a few months because of the recovery from COVID and all the work we've had to do for that. So picking up the new contracts has only been in the last couple of months. Thank you.
Councillor Wiley, coming back?
Yes, if I can come back. It is difficult because this is, as I say, such an overview. Now, my understanding from the report is that there will be some changes within that first year. By what you've just said, there won't be any changes at all. You'll be running with the same providers, all the same providers in all the same places, no changes at all.
So I can't confirm they'll be the same providers because this is a commercial process, so we have to go in with an open mind to any provider can put in for it. What I can say is the present specifications of what being delivered will roll over into next year, and then we go into the year of transformation.
So, if I may, so there might be different providers working out of different geographical places, which is one of the reasons for a substantial variation. Different providers will be another. There's been no consultation up until this point, which was very, very worrying. Now, you've just said that there will be a year full of consultation. That's putting a better face on it, but, well, normally at this position, I'm sure this committee would have heard more from the previous bodies, and they weren't particularly good, but even the CCG would have given us more than 4 pages to decide whether it's a substantial variation or not, especially when the papers does say that you want to work with your partners.
Councillor White, is that... I agree with you that there is enough paper, there is enough information. I think it's just for clear for Lee and for Mark about the question that, are you going back on the question about there not being enough information? Because I think it's got to be fair to the speakers to they know what you're asking.
Well, first I'd like comment on how are you working well with your partners when this is the first time you've brought any information to this committee?
So we did bring some information, not a lot, so we did bring some information when we started the process, so we did that as quickly as we could. We are working with the local providers. Obviously, it is a commercial process that we're going through. We all understand how contract processes work, but we are working with the present providers to look at what are they delivering against their specifications, what staff they've got, what resources they've got that are in the present contract. Just to say, we are not saying this will be driven not locally. I did 2 no's there. So this is all about local services. The provider, because it is a commercial process, I can't confirm it will be the present providers. I just can't do that because it is commercial. But we can confirm it will be local services driven for local populations. That's how community services are given. They're not away from your public. They're in your local communities.
Can I come back on that? Again, this committee in the past has heard lots about we will provide for the local community. You just included you will provide that in your local community. So does that mean everything that's in Medway now will stay in Medway? Because that isn't your history or the CCG's history.
Yeah, I'm ICB, not a CCG, so I can't speak about the CCG. What we're trying to do with this contract, some of the benefits of it are trying to look at the inequalities. We know because contracts have grown up over the years that we've got to refresh the whole of community services across Kent and Medway for adults and for children in Kent. There is changes in clinical care that we need to level up. So what might have been seen as a specialist skill 7 years ago, so I'll give you a for instance, pressure care may have been seen as a specialist skill 7 years ago. That's standard work for the NHS now and in our community teams. So there will be changes in how clinical delivery is done. That's all about how skills are developed, how we develop our workforce and the competencies of our workforce. We want that in local populations. So I can't confirm that there will be those kind of things because that's not how we deliver care anymore. So bringing everybody up to the same level in the national best practice models of care is what we intend to do. We also know that the way that we're doing this is to drive out inequalities, and you've got inequalities, so that's what we need to try and do with this contract, is make sure in your local populations across Kent and Medway for adults, everybody's getting the same quality of service in community services. For the NHS, community services is one of the biggest growth areas. So we all know, don't we, that acute care is not the way forward now. It's all about moving place to place and having services at scale in place. People want to be treated near their home. This is what this contract's all about.
Councillor Wilde, do you want to hold and come back with some more, or do you want to...
Just one final question, so if I do that now... Yeah, right. In the past, and if I can use an example, the dermatology... I shouldn't use that as an example, should I? Dermatology... Yes, right. That contract went wrong. Now, for whatever reason, again, under the CCG, but it took a long time for that then to get sorted out. In these new contracts, will you have natural, not breaks, but a time scale where you will be looking at the contracts? If things are going wrong, you will quickly, whoever will quickly step in and make them better than, not failing.
Yeah, I can't really comment on work that was done in CCG and whatever happened with that contract. All I can say to you is there is now a new governance process around contracts. My colleague sat next to me has been appointed as the Director for Contracts. There is monthly meetings with people who are delivering those contracts. For this particular one, in the prospectus that it sets out some of the transformation work, what we're trying to describe in there is what are the KPIs, what are the models of care that people must do. So monthly meetings around contract performance will be in place, and the mechanisms that you've got in contracts to trigger notice periods and the escalation up into withdrawing a contract will all be in the new structures that we're putting in place.
Right. Thank you.
Thank you, Councillor. Just turn your microphone off, Councillor. Sure. I will come back to you again, Councillor. We need to, just for clarity, before I move on to Councillor Prenter, I think from your point of saying that you have to be very careful what you say about the contracts. You can't also guarantee that someone locally is going to bid for those contracts, Lee. I mean, you can come back on it, but where you're saying it will be local services for local people, we can't guarantee it will be a local provider. They may not bid for it, so we can't guarantee that, right?
I can't guarantee that, but in the principles that we're trying to write, and these are with our legal team at the minute, what we're talking about is local economy development. So if you look at the terms of the ICB, there's 4 main core values that we're trying to do, or 4 main principles we're trying to do, and one of those is developing local economy. So, we'd be looking for people who get this contract to be making sure that they develop locally and sustain services locally.
Thank you, Lee. And because I'm such a good colleague of Councillor Wildy and all the members here, I think what Councillor Wildy was saying about the contract that he was saying that was rehashed and rushed through so fast, whether it was the CCG or whether it was any different past organisation, it doesn't matter. It was still within the NHS, and where it was configured really fast and quickly and changed, it was a disaster. And I think that's what maybe Councillor Wiley was saying. So when you're rushing things through and transforming very quickly, there could be a risk of disaster. But we can come back on that. Councillor Prenter.
Thank you, Chair. Thank you, Lee, for the update. Obviously, we all welcome any improvements to services here in Medway and an increased skills set for the professionals, because we want to keep all the services here in Medway, so we'd like them to stay here. My question's really about you've got these tests here, test 5, where it says the number of beds won't change because you're going to have, as you say, the care in the community. At the moment, even across Medway, there's the inequalities. So how are we going to be delivering these extra services? Are we increasing what we've currently got then to deliver these services if the beds aren't going to change at all?
So I do think the model is changing, and as Lee mentioned, there's more care being delivered in a patient or a citizen's own home. So that's the model that we're working towards, and it's the one which NHS England recognise, and we're being pushed and promoted to do more of care in a patient's client's own home. It's good for the patient. It means they don't have to travel to hospital, and technology and the way in which we deliver care has changed over the years, so we are able to deliver, much higher levels of care than we have ever been able to do. But there will still be a need for hospital beds. We're not going to get rid of those. But what we're looking to do is to develop those services which are delivered in a patient's own home, which I think is better for the patient. They'd much prefer to have that care delivered in their own home than having to travel to hospital and the relatives having to follow them to hospital on a regular basis.
Is this kind of the smart team services. I know I mentioned this before, but it would be wonderful if that was increased because it's a good service, but I don't want it to be reduced.
What does those teams need in technology? What is it in skill development to get them to that level of doing as much as they can outside of hospital? And as I've said before, this will only grow. You know, if the NHS is growing anywhere, it's in community services because we recognise acute care in hospital is not the way we're doing care now. It's mostly in people's homes, mostly in communities.
I've just got one more. And that moves me on to the digital improvements that you mentioned just there. That's working really well with the blood testing and other COVID tests, everything, online booking. That seems to work really well. And if that's going to be moved across more and more services for people to access in the community, will there be, with the improvements, sufficient development for those who are non-digital users? Because I wouldn't like any people that don't use internet to not be able to access the same number of appointments that others who can just pick up their phone and do.
Yeah, part of the redesign work is that we've done the equity and diversity inclusion assessments, and we know that there's a part of our population who just don't have the technology or don't want to use it. So we've always got to have those extra routes for people to come through, whether it's because it's just not for them or they struggle with it. So it will be part of the service. And the technology that we've got at the minute in the pilots and in some areas will be spread across. That's the whole thing about how do we get these models of care to work seamlessly.
Thank you, Councillor Brenner. Councillor Campbell.
Hi, I hope you can see my name. I've just moved my board here. So I have similar points to raise as Councillor Wildey did. I'm so glad you came in first. I wasn't going to use as strong words as you did, but, you know, similar questions. You said about 3 times that we're moving away from acute care into more community-based care. I don't think anyone in this room disagrees with that. I think it's just how we get there and what this transformation looks like. I think that's what the questions are. It's just how general that report is. It's just... Reading that, I don't think I really understand what changes you're proposing, what that direction is. It's very unclear. So based on that, it's really difficult to judge whether that's substantial variation or not, because what is that, you know? Anyway, I'll try and be more specific. One of the most obvious questions I had was, how much does this cost? What are the variations from your previous fees for the existing provider? How is that going to be different? What impact is that going to have? And surely that will have a bearing on whether it's a substantial variation or not. Secondly, I wanted to ask about the transformation. Again, I think we are all agreed that transformation is essential and that's where we need to move. But what you're talking about is 2 parallel lines of operation. One is the as a service that you're going to carry on. Simultaneously, you're going to embark on a year's worth of transformation activities. So that's 2 services almost. How is that going to be resourced, you know, within that? And I think that goes back to the cost thing. Is that going to be reflected in the cost? What new standards what are these new transformative standards that you're setting for the providers? You know, if it's Medway Community MCH, again, what are they going to be aspiring to do differently to what they have been doing for all this while? And a side note on this movement away from the hospital-based care into community care, as a consumer of the health services in Medway, my understanding was that that's already the existing model. Isn't that how it's all designed kind of already? That there's been more emphasis on community-based care and moving away from, I mean, it's almost seen as the last resort to send people to hospital. So I'm unclear as to what that extent of change is. Thank you.
Thank you. And I can understand that confusion or that not lack of clarity. Like I said at the beginning, we are trying to do a different way of doing contracts. And one of the things we don't want to do is say, this is how you will do it. So the national models of care set out the strategy of this is what you need to deliver for that patient pathway. We want to work with the teams to design how that's done locally. And there's a danger if you don't do that, is you don't meet the population needs of that particular place. So what we might do in Margate might be very different than we did in Dartford for community services or particular elements of those models of care. So that year of transformation is all about those national models, those national standards being adopted locally, designed with those local teams and embedded into that local area. You're right that the wave of moving things away from acute care into community has been going on for probably the last 7 to 10 years. What we're trying to do this is do it more at scale. So making sure that those inequalities are driven out, that it's the same community services across all those pathways. It's not pockets, and we have pockets. We have pockets in Medway, we have pockets of services in other areas, Dartford, West Kent and East Kent. We want everybody to have the same level of care that should be expected in the community services that we do. Just on budget, so the budget won't change. Is that gone better? Yeah, we'll try again. So the budget won't change. The budget's rolled over into the next few years. Like I say, I can only see the budget increasing for community. We're not saying we would take away the budget. We're saying we'd use the budget, but it might be done in a different way. So to get the maximum amount for the costs that we've got into the services, the new model should be much more efficient. And you had a fourth one. Just about the service standards, I keep going back to the pathways, and there is national kind of guides of what they should be, models of care, or particular principles of what you're trying to do. All the different pathways, they've been gathered to say, when you get into that year of transformation, this is what you've got to try and deliver. This is what we've been set to deliver nationally.
Councillor Campbell, would you like to come back?
About the cost thing, so you've not basically told us why that's not reflected in the report, and whether you have already got a percentage rise in mind, or, you know, I just don't have clarity on that at the moment still. I think you kind of didn't address that clearly. In terms of the models of care, and, you know, you've said it has to be a Medway-based model based on consultations, but surely you're not starting from scratch. You know, there will be knowledge around about models that have worked for similar demographic as what we have in Medway. There must be out there. Also, you know what has worked currently with the MCH provision. So there's something to work with there. I just feel like surely we could already have a framework of what this transformation looks like rather than starting from scratch.
Yeah, we've got pockets, but we've not got it all. And I think that's the bit, like we've said with children's services, we want to build on the best and not chuck that out. And that's why we want to do the transformation work around what does the national strategy say, what's happening in local population now, and what can we build to get to do the national models of care.
So Lee, just for clarity though, I think Councillor Campbell, please correct me if I'm wrong, is asking you what the envelope cost is here. Yeah. And we're not getting from you the envelope cost.
Yeah, to be honest, we're still working on that because there's a few things that are external to the present community contracts that we want to bring in. So we're just going through those. It's around 17 lines of other contracts that we think, because the models of care are going to change, things that could have been excluded could become part of this, which would give us a bigger cash envelope.
So Lee, where are we looking at on that? You must have a region of where that envelope is.
So for Medway, it's £43 million, and the total community contracts add up to a value of £200 million.
Thank you, Mark. Thank you, Councillor Campbell. Councillor Hamadishi.
Can you hear me? Right. Yeah, thank you very much. No, I support my colleague to the left. I looked at the report and you almost want to double click on some of the headings for the detail. And so it's lacking in a lot of detail, and where it is informative, there's not a lot of ambition in there. We mentioned transformation like 9 times, and my biggest fear is this is more like faster caterpillars changing opposed to transformation, because transformation requires a lot more detail to embed change. And this will just give faster caterpillars, which will result in people feeling like they're not supported particularly marginalised communities. So I've got 4 questions, very, very quickly. The first one was around pay structures. We talk about integrating services, so nurses, teachers, other professions come together. In care, we have Agenda for Change. So what are you doing to unify the pay structures so somebody in social work will not feel aggrieved by the pay structure, say in health? That's one question. The next question is all to do with voluntary services. We talk about community models and embedding and working with existing community teams and services. But you don't mention social prescribing once in the report. You mentioned voluntary services, but no mention of social prescribing. And there's a very distinct difference between the two. Yes, they're similar, but without talking to the heart of social prescribing, how then are you going to have local solutions to solve local problems? You cannot lean on voluntary services for that. The next question very quickly is around, we've got a 3-step process: principles, specification, and then transformation. For me, what's more important over this 8 to 5 year span is what happens post-transformation. We all got mobile phones on us that constantly asking for updates. So iteration is so, so important. The transformation is not the end goal. We need to be able to get, where's the feedback loop to inform how services are going to be continuously updated and managed. And then...
Councillor, should we let them answer the first one and then come straight back to you? It might
Sure,
be easier because you've answered some very good questions there, and I want to make sure they do pick up on them for you. You can just turn your mic off a minute, Councillor Amadishi.
So I'll attempt to answer the Agenda for Change question, and I'm sure Lee will jump in if he feels that I've missed a point. So I think the thing to bear in mind around the Agenda for Change is it's a national pay structure, so we wouldn't deviate from that. We're not within, in or out of London, so the pay structures are set. So I think from an NH point of view, we've got the workforce, we've got the TUPE information from those providers, so we know the bands of the nurses and the clinicians that are providing that care, and that's what we're expecting to roll over or to be continued in this new model of care. The voluntary sector as well. So while it's really important, to the community services to link closely with the voluntary sector, and we do have a number of voluntary sectors who provide some help and support, particularly around discharge. So we've got Ageing Well and British Red Cross helping and supporting us. We have also got a separate voluntary care strategy. So I think I think Lee and I just need to make sure that those two are aligned. So that's probably why you don't necessarily see a reference to the voluntary care sector within the paper.
Councillor Amadishi, just put your email.
Yeah, I do see voluntary services in there. No mention of social prescribing, which has a different model of operating.
And we do have good social prescribing models within Kent and Medway, and maybe we need to use that opportunity to, as Lee says, where we've got pockets or we've got good evidence of good practice, we need to make sure that those services are replicated across the rest of Kent and Medway.
Yeah, thank you for the question about the 3 levels we've got. In the contract, once we've locked the specifications in at year 2, then there will be annual reviews, there will be monthly and quarterly reviews, but we would expect people to keep up with those national standards, and that may be something that's not been done previously, but we would expect that to be done. In the NHS, we do this all the time. So I think previous colleague was asking about, transformation. Having worked in clinical services, we have to transform as we're delivering. That's how it works. So you develop, you do changes in your clinical practice, you do changes in your models of care, what we're trying to do is enable everybody to do that together in a way that makes it local. I'll just comment on social prescribing. I think we've got some real pockets of it. I was with a team this morning who were presenting what they're trying to do for winter in spreading social prescribing. I think what we're saying is it needs to be embedded in all the models of care, so it's not just in some pockets. Public need lots of information about what it means. So that was one of the challenges this morning about how the public know that they can ask about social prescribing and use social prescribing to get what they need.
Councillor Medici, but before I come back to you, I'll just let James come in on the social prescribing one for you.
Thanks, Chair. And just to reaffirm, we do have quite a good model with a good interaction and a service directory that gives people the options and the opportunities to be referred for lots of different services. And we're currently working with the ICB at this moment in time to expand one of our programmes. I think you're aware of it. The Hypertension Heroes has been shortlisted for the HSJ Awards, and that again links into the type of model that we've currently got. So I'm pretty confident we do have a good relationship in that space.
Yes, sir.
Sure, and just in relation to that as well, because you talk about inequalities that we're all here trying to fight against, really. But how can we ensure there's no inequalities in the provision of service providers with this new model? For example, those social prescribing organisations which are really small, they're poorly funded, they don't have the same digital tools, resources, the money that they get is scant. How can they bid for some of this work with this new model when they're penalised, but they're doing fantastic work, as my colleagues have just mentioned?
Yeah, so in the ICB principles, there's one around, that local economy growth, and that includes voluntary sector. So we are trying to work with voluntary sector. On the ICB board, we've got a rep for voluntary sector, and as Mark said, we're trying to have a strategy around how do we enable voluntary sector to keep going and be sustainable, and that's part of trying to get people to work together. I think some of the old ways that voluntary sector used to work, 5-10 years ago, where they were just providing one thing, what we're trying to give them is greater scope to try and go and be embedded in some of these contracts, so it's much more sustainable.
Thank you.
Thank you, Councillor. Thank you, Lee and Mark. Councillor Shucker.
Yeah, thank you, Lee. My question goes back to location. I've seen just actually firsthand what happens when services aren't locally provided in the last few weeks. There is real concern within the community about where services are located. So I'm going to ask this again, and I know it's been mentioned before. So are there any guarantees you can provide us in terms of location? I've got an example here with the TIA services that have been moved to Medway, Maidstone Hospital due to the unresolved workforce shortages issues, with no clear additional resources. So the clinic there are seeing twice as many people as in Medway residents. So any guarantees on that?
I think what we're trying to do with this way of working in the transformation is actually build sustainability. And some of the areas that we've just not had that. And we've got pockets of staff that is really short, and there isn't a plan around when people retire, change. As we get older, you can't do things that you used to do, standing on your feet all day, that got to me. So things like that, we need to make sure that we've got in our workforce that recruitment, retention, ongoing skill development. So in our local areas, we have that sustainability. We haven't got that in community services at the minute.
If I could just add one thing to that as well. So when we looked at this originally, we decided we would have it as 4 lots, and I think that goes back to the fact that we recognise that each of those 4 localities has slightly different approach and slightly different needs, and therefore, rather than doing one single large contract for 200 million, we've maintained it by locality. So there is an opportunity to tailor those services for the citizens and populations of each of those localities, working and engaging with the population and the likes of the councillors here to make sure that we get the right services in each of those 4 localities, rather than that one uniform contract or procurement across Kent and Medway.
Councillor Shucker, or do you want to come back, Georgia? Okay. Councillor Bray.
Thank you, Chairman, and thank you very much for being here this evening and taking our questions. Just going through your report, just want to just understand a little bit more about what you're proposing here, because according to your report, you've extended the existing contracts until the 31st of March 2024. So 31st of March, it's cut-off date, and on the 1st of April, you are stating here that the new contractors, the new contracts in place, new contractors as appropriate, are going to be ready to start the work. Understood. But looking at the list of contracts that are being considered here, there are a lengthy number of contracts, very complex contracts. And here you are working until 31st of March, existing suppliers, contractors, and at the same time, underneath, you're working possibly with a new group of contractors. Some of them have never ever been here before, never undertaken this work before, but on the 1st of April, you state here that they are going to be ready from day one on the 1st of April to pick up and run with the ball. No dropping the balls. This is not England playing Argentina or England playing anywhere else. This is about the people of Medway. This is about making sure that the people of Medway have got a service on the 1st of April that is as good as, if not better, than the service that was here on the 31st of March. That's quite a tall order. Now, what I'd like to know is how are you going to operate in such a way that all of this is going to happen by the 1st of April? Because if it all does happen by the 1st of April, what's the need for the transformation? I know the answer. The answer is that on the 1st of April, people are not going to be ready to pick up with the ball and run with it. On the 1st of April, they're going to be the contract holder, and then over the next 12 months, you are going to go into transformation, or better still, development of that contractor to provide the service that is going to be required in Medway. Plus, you've got the other areas of Kent, but let's just concentrate on Medway. Sorry, when we start to talk Medway, I become very focused, a little bit like a racehorse. I'm thinking Medway, Medway and Medway, and I don't give a monkeys about what's going on elsewhere. I want to make sure that the people of Medway get what they deserve, and that is the first-rate service. So, and I can't see, with your programme and your proposals, how on the 1st of April we're going to go bing, bang, wallop, we are there, we're going to go straight in, no business change, unless, of course, you've already determined who the providers and the contractors are going to be, and I won't ask you to answer that question because that way you will be predetermining who you're going to have in place. So we can only assume that all these are likely to be new contractors under new terms and conditions, people being tupied across from one area to the other, which is quite normal in this particular field. So how are you really going to be able to control this from now right the way through to the end of March, then from the 1st of April right the way through for the next year? Because we've got to look at continuous improvement. We've got to make sure that we're getting the service that we've got today. We've got to make sure that the cost is right. We don't want a rerun of the ambulance service a few years ago where it was determined when the contract went to somewhere else, they suddenly found that the new contractor wasn't given all of the area that he was supposed to cover. End of story was, that company turned around and said, you can have the contract back because you didn't provide, NHS, you didn't provide us with the right information, therefore the contract's not valid. We don't want to be in that position. Not again. I saw what it did to Medway in the past, and I don't want to see the people of Medway suffering because of that. People being left at home waiting to be picked up for an appointment that was due at 10 o'clock. Ambulance picks them up at 11 o'clock, and then when they get here, they wonder why they can't get their appointments and seen properly. So it's all these sorts of things that are there, hidden in the background. Past experience has shown this is not going to be an easy task. Please convince me and my colleagues that you are going to be able to manage what you say you're going to give. Thank you.
Thank you, Councillor Bray. Very insightful questions, so thank you for that. I'm not sure I like the horse metaphor, but there you go. So what we couldn't put in the paper at the time was we've renegotiated a transition period. So you're completely right. You never want to swap a service from one day to the another between a provider. So with the three present providers of the service have agreed that we'll have a 6-month transition from that 1st of April for 6 months. While that transformation across the year is going on, they will still manage that services. So there will not be a from one day to the next transfer. And that gives us 6 months to work on how we move. I can't say who the providers will be. And as you said, I just can't say that. We're as open as we can be around everybody's entitled to put forward. It's a commercial process. We can't preempt that. So our three present providers have agreed the transition. Letters have gone out to them to agree that. And that's how we're going to try and do the seamless transfer between the services over that 6 months, if they're not successful.
Sorry, just very quickly come back on that. Thank you for your response, but basically that's not what the report says. This report says on the 31st of March, end of contract. 1st of April, new contract. Doesn't talk anything about transition from one supplier provider to the other. You've said they're going to be ready, delivery of the new contracts by the 1st of the 4th, 2024 deadline. Not mentioned in here about the transformation, not mentioned in here about how this is going to spread out, how various companies are going to work together. Really, by us sitting here and asking you questions, we're finding out more and more about the information that should have been provided when the report was first put together and presented to this committee. So forgive us, but you've failed. You've fallen over at the first hurdle, I believe. Thank you.
Thank you, Councillor Bray. Councillor Hyde, I will come to you. I'm just going to let a couple of us come in. Councillor Name.
Thank you very much for the wonderful presentation. I think mine also follows from what Councillor Bray said, because you spoke of the specification, and then I believe if we are talking about specification, it should give us some pointers that this is what we should be expecting from the services that you're going to provide if we enter into the new specification. But it seems like you've spoken about the new specification that is going to move from the old to the new one, but there is not much for us to, something to yardstick to measure you on. If in case it doesn't go well as planned, you said there will be a transformation from the previous specification to the new specification. So I believe if we don't know the new specification, how would we know if something is going wrong within the transformation? Because we don't know the new specification. So without a specification, something goes wrong. How do we hold you accountable that you said this new transformation or this new contract that we're going to enter in, we're going to get this, we're going to get that from that new contract or that new transformation or the new model. This is what we're going to get. No specification. So I don't think there will be any yardstick that we can use to judge whoever takes over that new model or new contract.
Thank you. So as I said at the beginning, the present specifications will roll over. And we will bring to Ask and Hoss throughout the year of transformation the updates on where we're up to with the contract for the particular models of care. Community services hide lots of different models of care, and that's, as we've said previously, there is a lot of services now in community. Just bringing a community contract will not give you the detail that you need to say, is this what the citizens want in their local area? So, you know, the present adult model has 9 different streams, intermediate care, community nursing, all those kind of things need to be refreshed and worked on how they work locally and then written up so that you can see these are the things that are coming into place. We can't do that at the time because we need to do the transformation work, but from the 1st of April, present specifications will roll over.
Come back, Councillor.
So if I may ask, so if you start with the new, you finish it with the transformation, and you start a new specification, and it goes wrong, what happens? Because we don't know the new specification, You started a new specification because you started a transformation. Now, in the middle of the way, we realized that because we don't even know the new specification. In the middle of the way, you come up with a new specification. What assurance do we have that that new specification is going to work or it's not going to work? Because we don't know the specification from the beginning, and in the middle, you come up with a new specification. What about if the old specification is better than the new specification that you came up with? How do we sort that out?
Yeah, so the specifications going forward will be based on the national models of care. So they define for us most of the services in adults and children's have best practice, they have data, they have quality checks that need to be done. That all needs to be built into the way forward. We have a really strong governance in this programme around how that will be done through that year of transformation. Like I say, it will be monthly checks. The way the clinical changes will be delivered will be through focus groups. We run them now in other areas around elective care, emergency care. That will all be the new way of working for us to make sure that the clinical changes are embedded in a safe way.
Thank you. I've got Councillor Crozin and Councillor Galvin. Councillor Crozin.
Yeah, thank you, Chair. Oh, thank you. Yeah, we're here tonight to establish whether there's going to be substantial change to the service that we're getting. It would seem to me that we're not going to get any substantial change, until August of 2024, when we come to the end of the transitional period. And it seems to me the way it seems as if you're selling what you're trying to do here this evening, as if there is going to be substantial change. But there is no definition of what substantial change is. So my question is, are we too early looking at whether this is going to be substantial change? Because we don't really know what's going to happen. We've got no idea what's going to happen until certainly within the first 6 months of next year.
Councillor Cruz, I think it's a good question. I think that's for the committee to decide. It's about us being unsure. It's about us making sure there's clarification. We don't really know what will happen going forward, and maybe we want more information back. That's what a substantial variation would allow us. They would, the provider, the ICB would have to report back to us and do the consultation properly with us. But that's for us to decide this evening.
The way that it's been explained to us, it is substantial change. And I know there's no definition of substantial change, but you are talking about substantial change in the way that the service is delivered. So, I think perhaps my follow-on question is, what are the implications of us saying that there is going to be substantial change? What advantages to us? Perhaps what is their advantage to you or disadvantage to the ICG?
I think it's a really good question, Councillor Cozin. Can we hold that to the end bit before we go into our debate about whether we think it's a substantial variation? That would be easier, because it's a very good point to make around if we make that decision about it being a substantial variation, then what does that mean? So let's come back to that. If that's okay, if you hold that as well. Councillor Galvin.
Thank you, Chair, and thank you, Mark and Lee. I'd just like to explore three areas, because I do feel this is covering a huge area, and the actual information that we've got before us this evening is scarce to say the least. I'd just like to look at three areas, and happy if you dealt with them, would be happy if you dealt with them individually. First of all, the elective community hubs. I would like a little bit more detail about how they're going to work. And I noticed when you were asked a question earlier about guaranteeing location, you weren't prepared to give a guarantee. And that worries us here. And I'm sorry if I'm sounding like a record stuck in a groove on this one, but unfortunately, we have had a long history here in Medway of Medway's residents losing services out of Medway and having to go elsewhere for their treatment. And I do understand that some levels of care which are more specialised, you do need clinical centres of excellence. The trouble is we never seem to get one in Medway. which is a shame. And we're not talking about that. We're talking about which is basic community care, the bread and butter stuff, not the exciting stuff. So I would like a guarantee that this non-exciting, this basic stuff is all going to be available here in Medway.
There you go. Thank you for the question. As I'm saying, I can't see anything other than community services growing. So, you know, we know our populations are increasing. They are going to need that, as you say, that basic care in the community. So I can't see that. Yes, we do have complex services that we have to try and align and make sure they're in the specialist centres. But for this kind of service that we're talking about, it will keep growing. We've got an ageing population. We've got a younger population coming through. They are going to need the community service that they want at scale, and this is part of what the service is. Some of the innovations that are in the community contract, you listed one around the elective hubs. Out-of-hospital care in hubs is getting much more prominent. We know that that gives us much more efficiency to local populations, so things like endoscopy, day surgery, primary care interventions done by specialist GPs. How do we create those hubs in local areas that give us that scale? And in the community contract, it talks about how we're doing that. And that's one of the things we'll be figuring out during that year of transformation. Where are those hubs going to be? I know we've been working with you lately around Sheppey and putting more services at Sheppey. So the frailty model over at Sheppey is a really good part of making sure the underpinning services are in the right locations at scale.
Thank you for that. Yes, you're right. This is a growing area, particularly with the change of demographics, but it's very noticeable you're not prepared to give us this evening a comprehensive guarantee that Medway will have a comprehensive set of care in the community. You're not prepared to give that. That I will have to note, so we'll move on. Another good thing you talked about was...
Sorry, Councillor Garvin.
Yeah, can I just clarify that? Because I thought I just did say that. So what I'm saying to you is community services in Medway will do nothing other than grow. That's what we're trying to do with this contract. That is out of hospital care. That is happening across the NHS. I can't see that being reduced in Medway. So I am confirming that that's what we will be doing. That is what we're trying to do with this contract. We're trying to get as efficient and as effective services as we can to meet the needs of your population and the needs of your citizens. Thank you.
Thank you, Lee. Back to you, Councillor Garvin.
Okay, right. We'll move on. One of the things you talked about, and it sounds very sensible, is providing a great more range of care within people's own homes. And again, with an elderly population, increasing elderly population, that's a very, very good thing to do. And quite rightfully, you mentioned that patients should only have to tell their story once. It's terribly frustrating having to tell the same thing time and time again. To do both of those things, to only have to have the patient tell the story once, and also to have care in the patient's home, will require a very sophisticated mobile IT system. Do you have one that's available? So every person that's doing this care will have a device that will be able to talk to every other device, so every patient's details in. Then the question is, who will actually own this system? Will it be the contractor, or will it be the ICB, or whom?
So we do have technology and community link-up care. I think one of the biggest innovations we've had since COVID was how we do virtual wards. So virtual wards are how you do really complex care in people's homes with point-of-care testing joined up through the patient record. You can view those from a distance and make sure that that patient's monitoring is done. The whole point of this exercise going through the transformation is to give as much technology as we can into those local teams to manage patients in their residence. That might be in the home, it might be in the care home, it might be in a hostel, wherever it is, having the technology to do that. So yes, that is the intention, to make sure we've got the technology at point of service so that people are enabled to do the care that they need.
And just finally, there's one line here which repeats itself when you talk about service area and the existing service included, is end-of-life care. And I have to say, my personal family experience of dealing with end-of-life care for my mother-in-law was quite a shocking experience. And I'd have to say, this is an area, please try and put some extra resources in, because the lack of continuity between doctors in the primary care system means that, certainly in the case of my mother-in-law, in the last few days of her life, there was no continuity of care. Drugs were supplied, then taken away at a whim of the different doctors appeared. And last night she died in agony because there weren't sufficient drugs in the house for anybody to administer to her. So that's an area, please go and have a look at. And I've heard the same similar stories from a lot of other people in Medway's community. So I think this is an area that it's going to happen to all of us. The old jibe goes, there's only two certainties of life, death and taxation. So we've got to get this one right. And at this time, for an elderly person to die in agony, to me, it's just not acceptable. So I'd be very interested to hear what proposal you've got for a more joined-up system of end-of-life care, please.
Thank you. I'm sorry to hear your story, and we do hear these stories, and it's always distressing, isn't it, to hear what's happened to people's families. The palliative care team, and this is a good example of what I'm talking about when I'm on it. I'm talking about models of care. So what we've done is looked back across our 4 areas and said, have we got a palliative care service that runs 24/7? Is that at the scale that we need? And can we have some principles? So one of the principles that's been adopted is there should be no spare capacity in palliative care if somebody's waiting. And we're implementing that for winter. We've just let a separate contract around home care at night so that there is palliative care services across Kent and Medway at night. We're also looking at trying to put this in before winter. We're rushing to do it, that we've got a coordination team that people who deliver palliative care, and that can be any healthcare professional nowadays, that they've got someone to talk to who's a specialist, and that being available 24/7. Also that there's a dashboard around where the capacity is. So we implemented it in winter last year. It was very paper-based of just trying to get bed numbers so we could maximise the capacity. We're trying to do all that in a proper service 24/7 for everybody.
Thank you, Councillor Garvin. Thank you, Lee. Councillor Wildy.
Sorry, thank you, Chairman. Councillor Shocker sort of covered some of what I was going to ask about the workforce. We all know we're very short of GPs. Community nurses, you mentioned quite a lot. The last statistics I had of those, we are very short of community nurses, pharmacists, and I'm sure there's plenty of others. But when you've been talking around this, I think Mark said you've got the workforce, and I think, Lee, you said there's shortage in pockets. So I understand is that the general overall picture, which I assume Mark referred to, and you were being more specific, so I'm not picking up on that. But we do know in pockets there are very much shortages. If you change provider, and as you don't know you're going to or not, that always comes with moving staff from one provider to another. You always lose some of them. So that may be one of your hurdles. Have you looked into and thought about that? And we've also talked about technology. Now, technology is great, except for that some of the people you're talking about, my 96-year-old mother-in-law, at the moment, she can barely use the phone because she's getting forgetful, etc. So she gets, in her mind, 2 or 3 calls a day from the GP. Me and my wife believe she hasn't heard from the GP for the last 6 months. So it is very difficult as a family to know what help she's getting and, well, all of the problems that go with that. So this treatment in the community is, well, it's not in a good place for some people, and I'm sure it's working better for others. If I can stop there and come back.
Yep, Lee.
Yep.
Thank you. I'll just do workforce first. I think the models of care work is showing that our traditional ways of managing our workforce just aren't going to meet the scale in the future. So we all know we've got a shortage of GPs in our areas if we follow that traditional model. But actually, care delivery does not rely on a single GP. It relies on a multidisciplinary team, it relies on qualified staff, and it relies on trained staff. So if we are really going to get to delivering the capacity that we need, we have to think about using workforce differently. So I think within the models of care, that's what we're trying to get to. How do we enable people with technology, but also develop the skills and the abilities of people at the top of their license, whether that's you're just trained or whether you're qualified, including all allied health professionals and medical staff. How do we really make sure that those are at the scale that we need to deliver those? I think there's the second question around what I would say is your care record. I think this is some of the things that we need in place across everybody. So it should be common practice that if you're a patient in the community, there's a shared record that somebody could look at. And if you're struggling with that as a patient, that you've given permission for your relatives to own that as well. I've got that with my mum, so I know what daily care she's getting. When her carers go in 3 times a day, I can see what they've done because she doesn't know what they've done. She just thinks they've turned on the TV. So, you know, there is things like that that should be in those models of care that are the best practice that we're talking about, should be at scale across everybody, so we've got to that standard.
If I can quickly come back, because, well, we've both mentioned GPs, but there's shortages even within Medway. Some areas are very short of GPs and others, I wouldn't say there's more GPs, but they seem to limit their patients that they take on their books so they can cope better, which seems to me a better model, and I wish my GP was one of those.
Councillor Wiley, can we keep to the contract?
Well, you know, but that shortage of staff and shortage of nurses. But moving on, if I could ask Leanne a question. Now, I'm not very happy with these papers and the way we've been informed. Can I ask, have you been, has the partnership been better from your perspective? Have you been kept informed to a higher degree than we have? Or even more, as much as you would have liked?
Councillor Wiley, Leanne, just before you come in, are you asking the officer whether she's been more informed on this paper with the ICB? Is that the question you're asking the officer now? Just to be clear.
That, and with the partnership working on this issue.
So you're asking how the partnership is, but also does Leanne know more than what we do with regards to this paper? Okay, just to be clear, Leanne, sorry, I just want to make sure you know.
Thank you, Councillor. In terms of the paper itself, I'm with you. I saw it in line with everyone else. But as far as the working and the partnership goes, you'll know that I sit on the ICB as a local authority partner member. James and Jackie are involved at the different regional, local level. So from that point of view, yes, I can absolutely say from a partnership point of view, no problem whatsoever. In terms of the specific paper, I got the same paper that you did.
Right, so you weren't given, on this issue, you weren't given any more information than we have been?
No, the issue, there was the informal briefing, there was a variety of different opportunities around this item. So yes, as officers, we were aware of that. But in terms of the paper,
So, Councillor Wiley,
thank
just for reassurance, we've had the same information. You've been in all the meetings I have. We've all had the same information, including officers, during this process. So, if you've got any more questions, I've got 2 more councillors to come on after you.
No, I was going to make a comment about whether I think this is an SV, but you suggested we do that later, so that's fine. Thank you.
Definitely come back to you, Councillor Wiley, on that one. Councillor Printer.
Thank you. It's just really to follow up Councillor Wiley saying about the workforce planning. Are you able to reassure us that the skills set that we're going to need for this greater community workforce that we're going to need, because our services are going to increase, is already being planned, ready for when that happens? Because obviously it's going to be gradual, I know that, as you decide if you're going to transform greater and greater services out into the community. Is the planning already in place? Projections for training staff, so they are still here in Medway and the services are here, so we don't have this health inequality that we're seeing at the moment. And I've got another one afterwards.
Thank you. In basic terms, yes. So I just have to be careful what we've called it. So we have started a skills centre. We've not called it that. So we did that about 6 months ago, knowing that we got to start to grow the staff group. This is a bit like the medical school. So we know if we do training locally, you tend to stay where you're locally trained, and that's the evidence. So if you train as a doctor in your local area, you're more likely to train. So we've got the good news about the medical school that's coming underway. That's part of the succession planning for these kind of developments. The second one is the centre that's already up and running for developing non-medical staff, so your allied health workers, your nursing staff. So that's already started. What we want to do is move that to scale.
Thanks. And I've just got another one following on from Councillor Anang, who was, I just wanted to be clear, because I want to be clear now that he's asked those questions about the approach to the contract and the transformation period. So if you decide when it comes that you're going to continue with the existing provider, you're going to switch over and it's just going to be transformation to follow make sure you're following the national standards. But if it's going to be a new provider, there's going to be a 6-month transformation where they're working together. Is that right?
So there's 2 parts to it. So there's the 6 months of transition. While that transition is going on, they'll also do the 12 months of transformation. And that's really important. I've gone through this myself when I worked in London, where we did the same kind of thing. As a new provider, you want to be involved in it. So you don't want that contract that team just to be given to you at the end of the 6 months. So you want to be dovetailed into that change.
So it's unlikely to be ending on the 31st of March?
Councillor Prenter, you just put your microphone on.
Sorry, it's unlikely to be a switch over one day to the next. They're going to have
it will be 6 months
a
of transition
period.
Yeah.
Okay.
Yeah.
And all with the idea that you're following the national standards.
Yes.
Yeah. Okay. Thank you very much.
Thank you, Councillor Prenter. Councillor Cook.
Yeah, thank you. Really appreciated it, and such an interesting discussion, and it's really kind of got me thinking around how we're talking about transformation and significant change. And we've talked lots about KPIs, and I've heard you talk about, national benchmarks and that kind of work. The national benchmarks and best practice you've been talking about. And some of that is in the intentions that have been shared in the room. So you've just shared a really specific one about end-of-life care. We've spoken a lot about location, and wanting things to be in Medway. And I wonder how that translates into the process around how are we certain that we're holding people to account in the right way, that broad picture, not the individual contracts, but overarching, so that we can be certain that the change is actually going to happen, it's going to happen in the way you intend it to be, because there's such a danger in writing it as we find it out that it's not actually going to look like what we wanted it to. And then I feel that with that, I then can't comment on whether it's significant change because I'm not certain about where it is we're wanting to get to, particularly when it comes to things like government best practice. Now, is that the goal or is that the baseline? Are we talking about the people of Medway aiming to get what the government believes they should be getting, or are we saying they should be getting more? Because when we're then talking about that, and we're talking about ensuring it's in Medway for them, so that people don't have to travel when they're unwell, ensuring that there's not wastage in the system, ensuring that things are joined up, how are we certain then that cost isn't going to get away with us? And so there's that kind of really big question there. And then with that, the kind of specifics of what you've spoken about with the 6-month period, even does that mean that we're paying for both providers at the same time? And how does that addition to these papers change the cost? Because, again, we can't do all of those specifics today, I understand that. But it does affect how significant change is going to be. Thank you.
Can I just ask you to clarify your question? You gave me quite a lot there, so just do we mind just clarify the question?
So at what point do kind of competency-based benchmarks come into the process?
Yep.
That we can all see how significant and how change is going to be measured, particularly then with the question that was asked quite near the beginning around things like cost, and how are those principles moving into specific benchmarks in all the areas we've spoken about?
Yeah. So I think that the general thing is that through this year of the change that we're trying to get, where the teams are working together, they're doing the consultation with patient groups, involving users into that, we would be bringing things to HASC and HOS to say, in this particular model of care, this is the change that's coming. And I can't emphasise enough of, we don't want to just tell people what to do. That is a really old way of doing stuff, and it does not work. So actually getting people, the clinical teams, to work with their users and say, this is what the standards are telling us, the national best practice or the models of care, how does this work locally, is the way to go. It's the only way that we can really get the efficiency, the effectiveness of services. That's what we're trying to do. It is a different way of doing contracting. We know that. We know there's risks to it. That's why we've got the really good governance process around it. But that's our intention, and the new ways of the ICB working, that's our intention to get this to a level where we know there's sustainability and scale for the patients that we need.
Thank you so much, Councillor Cook. I think, Lee, you can see we've got a really good committee, really good questions. I'm going to ask some questions, and I think some of the questions, parts of it may have been picked up by members, but I don't like to feel left out. But it might also help for some clarity as well. So there might be quick answers for you, Lee and Mark. But first one is about the procurement process and of the scale of the procurement process that you're going to complete in 3 months, and whether it could really be robust. You know, you're preparing to award by December, which means bids at the latest, you can correct me, but in my mind, bids at the latest by mid-November to be able to score it appropriately and then go through the boards, etc. Also, I understand at the same time that the ICB are going through another internal reorganisation during the next few months. You don't have to confirm that or not, but I understand that's correct. Am I right in saying that for providers, this means it's just about a 5 or 6 week period, including clarifications to respond? Is that really best practice of a procurement process of this size?
There you go. So what we did at the very start of the procurement is if you have been in procurements previously, some of them can take 2 to 3 years. That's just not going to work with the backlog that we've got in these large-scale contracts. So what we did is we went through what is I call it chunks of contracts. So can you actually speed up certain parts of it? The only thing that's set is that legal bit of letting your documents out and then getting the documents back in. That's the set standard, and it's about 4 to 5 weeks, and that's what we're sticking to. The rest of the process is how you actually chunk up the work that needs to be done, and can you bring people in and be pretty agile around getting to do that transformation in those models of care.
I think my question was being whether it's robust and whether it's good practice, where it would have normally taken 2 years, or, I mean, we don't want things to take 2 or 3 years, but you're going to do it in, I mean, we don't have to respond to that, but you're now going to do it in such a short window, and, you know, for me to be assured that how you can shorten something down from that big down to that small, it leaves me a little bit nervous. The next one is, do current specifications, and therefore those for year 1 of the contract, actually reflect the services that are going to be provided in Medway? So services have been transformed over the last few years. Members have mentioned that already tonight. and their specifications don't really reflect some of them of what they're actually delivering. So if they don't, then there could or would be a substantial variation during the transformation year if a new provider is appointed and provides only the specified original specifications. So they go back to the original, but they're not going to provide the ones that maybe the provider's already providing because it's been changed. That's a concern. So am I correct in saying that?
So what we've done is gone through a process of updating the current services. So you're completely right. What we want to make sure is all those tweaks that have been done over the years are captured in the present specifications. So what services are delivered now is written up, and that's what will go forward on the 1st of April.
So a new provider that's appointed will work to the adapted, mucked around specification, not an original specification that you're planning to put out to everybody.
The specification of the present service delivery.
Okay. My next one is: will the contract value for year one of the new contract be at least the same as the contract value for 2023-24 plus planned NHS uplifts? If not, there is likely to be a substantial change. I keep going back to this substantial part because every time I hear, and you can understand this, every time I hear in your answers, even to questions tonight, I keep saying to myself substantial. So, you know, will the contract value, you don't have to answer it you don't have to give me a long response, Lee, but will the contract value for year one of the new contract be at least the same as the contract value for the 23-24 plus planned NHS uplift?
It's rollover. There isn't a planned, and there isn't in any service, an NHS uplift. So there is around the negotiations around agenda for change that usually comes through each year. There isn't around services. We get a demand uplift. We don't get a financial uplift.
So if there's not an uplift, then there is likely to be a substantial change to services so that the contract can be delivered.
The present budget would roll over, and that's probably what's happened the last few years. So to us, that's not a change in, you know, operationally you manage to that budget that rolled over.
Okay, so given my questions 2 and 3, which I've just asked you, can the ICB give this committee the assurance that the ICB will make good any funding shortfall due to inadequate specifications and ensure that other partners, e.g. the council, us, which we're looking after our money, will not incur additional costs in year one of the new contract?
So we are going through the diligence, and that's one of our risks. So me and the financial director, you know, we've been going through the risk around, are we aware of everything that's in the current services? So is there some backlog of patients? Is there a waiting list of patients? And what would that mean if we moved it forward? So yes, we are saying there will be a financial model that deals with what currently the services are and how they move forward.
So you are giving the committee the assurance that the ICB will cover any shortfall in the new contract?
For the contract in community at present, yeah.
But not, what about following that?
Well, it's within the scope. So within the scope of the community contract, yes. If there's things outside of that, I can't guarantee that because I wouldn't know what they were at the minute. Okay.
Do you not think that it would be, and members have said this really, really well tonight, do you not think it would be much better for local people to begin to transform services with the incumbent provider that's here in Medway already, so there is no loss of time and momentum caused by the tender process and a potential change provider? I know members have said that in their own different ways tonight. This would surely enable smaller changes to be made immediately and would ensure that if in any future procurement, providers are tested in their ability to deliver the new services in Medway within the financial envelope that you're giving.
I think the difficulty is the tenders are running out and we've done extensions, so you get to a point where you can't keep rolling them forward. You have to go out to a commercial process. So all 3 community services have been transforming or doing improvement, doing tweaks to the service for the last few years that they've held the contracts. That's what we do. That's what we do in the NHS. The issue for us is the contracts are running out. We can't extend anymore, so we have to go to a procurement process.
Okay, the risk current service provision and risk a substantial service variation. You can see where I'm going with this, Lee. You know, every time I look at these elements, substantial variation comes in. So, you know, especially as any procurement process or change of provider can unsettle staff and maybe increase turnover. You know, staff may leave, staff may walk. Then what? If you lose staff in the contract.
Yeah, and that's why we put in the process of there'll be 6 months transition and there'll be that year of transformation, so we don't disrupt the services. We're doing that work alongside. We do lots of change in the NHS, so I've got 11 streams of work that are going on around making sure national standards are put in place. Emergency care ready for winter. If you read on the websites, there's the national winter plan that's come through. The amount of change in that we have to embed in services is probably more what we're talking about than the community service. So we do this all the time. It is something that the NHS has to do to keep up with the demands that were expected.
But you also do know, Lee, that when sometimes there's new providers, new takeovers, TUPEs, etc., it unsettles staff and they use their
That's
feet,
right.
they walk.
Yeah.
And that could cause a real risk with a current service specification that you're running. You do recognise that could happen?
I do recognise that in our risk management, we've got procedures being developed around the things that could happen. So how we maintain services while those transitions are going off. You would expect that from me. So the teams are doing desktop exercises to see what we would do if providers did start to lose staff or if they lost senior staff.
You can tell, I'm on my last two, so you can tell I had plenty of time till 3 o'clock this morning to write these days. I mean, we know services in Swale are not the same as Medway, but will Medway resources be diverted to balance services in Swale? Because that is a real concern of this committee in the past, during the first year of the contract. Or will the provider be required to offer different services in Medway and Swale?
So I think it goes back to the principles in the contracts and the way that transformation has been done is we're expecting to level up across Kent and Medway. That can only be about developing services, so bringing all those equalities to a level where we're meeting those national best practice.
So there may be resources diverted to Swale to bring them up to the same as what we are. Because I remember from your Kent HOSC appearance, you did say that you want to see services the same everywhere. Obviously, Medway's, you know, we want services for residents everywhere across Kent. Of course we do. Medway is a very, you know, heavily populated area. I don't think we can afford to see some of our services slimmed down and transferred to other areas if you're not going to fund places like Swale yourself with extra money.
I can't see services slimmed down. What I can see is, like I said earlier, around that skill development, some of the ways that we worked previously may not be the way that they wanted to work, and that's about efficiency, training, building competencies. So some of that might develop people who we then move around, but I can't see the services being at a level lower than what you've got now.
Okay, my final one before we come to the big question. I think if the HCRG didn't pass on the recent pay award to staff, this could mean that any staff TUPE'd over would be entitled to an increase in pay as part of a pay equity, where if they're being transferred over to a new provider. What is the amount, and has this been factored into your financial envelope? If you've got workers that have not been given that pay rise, that pay award. Maybe Mark.
You're giving me the difficult questions, aren't you?
Yeah.
So I think the previous contracts were different around NHS staff and non-NHS staff. What we're trying to do within this contract is make sure that we're maintaining that level that Mark talked about under Agenda for Change. So that's one of the questions we're trying to work through. If providers did come forward, and you know, we're trying to be as open as we possibly can about anybody who would want to come forward for this contract, what would that mean in the workforce and the costs of that workforce? I'm not there yet on that answer.
So at this moment in time, thanks for the honesty, Lee, at this moment in time, you haven't factored any amount in the financial envelope for staff that you want that pay equity, i.e. like Councillor Amadisha was saying earlier, you want pay equity, but we've not put anything in that financial envelope at this moment in time to ensure that.
We know the difference in value, but we don't know the solution's not there yet. We're still trying to work that through.
Which could be substantial for a member of staff transferring to a new provider on different pay. That's quite a change, isn't it? With regards to pay equity in a new contract.
That's right, and that's why we've not got to the solution, because some of it is bound in what the NHS says it will give around non-NHS and NHS under Agenda for Change.
Okay, so the committees have heard, I'm always very clear on my concerns, and I think you've heard the concerns from the committee. I think the committee would like me to answer this last question, ask you this last question, and I think it's a really important one that was brought up by Councillor Crozier earlier. That's why I said we'll bring it up now. is, finally, can you tell me what a substantial variation decision, if we was to say yes this evening, would mean to the process you're carrying out?
Yeah, so this is a difficult one, and Hosk asked me the same question. I think it would delay the transformation work and letting this contract for a substantial amount of time. And there's reasons for that. So the team that are working on this contract, as I said, we've moved people in to try and help being efficient around I call it chunks, the chunks of the process that need to be done. Those staff will have to go on to winter. So, you know, that's my focus. As soon as winter starts, 1st of December, we go into it. There's 4 months where all the team in the ICB in my areas will be concentrating on winter management. That will take 6 months out of this process. We then have to come back up and get things, we'd have to redo the specifications, we'd have to go back through the briefings, that would be another 6 months. And then we start going into the actual normal process. We think that would be about a 2-year delay. So that's substantial to us around how would we manage that for 2 years, knowing that we would not be having this transformation delivered for another 2 years.
I think it'd be fair to say, you did say earlier that normal processes took normally about 2 years to do. So if you're not going to rush a process, it would take 2 years. I think that's what, I'm not putting words into your mouth, Lee, but really when you're telling us it could take up to 2 years, you was saying before that actually a normal procurement process, some could take longer, but a normal procurement process would take 2 years because it's done robustly and more, you know, effectively without the risk.
Mm-hmm.
I'm saying that. Okay. James.
Thanks, Chair. Just when you were touching on the point, it's fine, Chair, you are the Chair. Just to remind members that the workforce bits that are being discussed this evening, we do have as a system a workforce strategy that's being developed in partnership. So it's local authority and the NHS that picks up some of the elements that you were referencing around the skills agenda, training and development. And that forms part of the integrated care strategy. That strategy will clearly come to this committee before it is ratified. But I just want to give members that assurance. And then the second point, because I was sat just listening to the colleagues speaking about the role of these community services. Remember, members, we're doing our joint local health and wellbeing strategy now, and the remit of this, the community services help to deliver for our population. So again, that strategy and the work that's being discussed here should align to the local priorities. So I just wanted to make those 2 points, Chair.
Thank you very much, James. And you should pull me up because I forgot you at the last meeting as well. I'll never do it again, honestly. I mean, you can tell me off. Members, we're at the end of the questioning now. I think Lee and Mark, thank you so much for being upfront and honest with our questions. You know, I think from a chair's point of view, I'll be opening up to members to make a proposal, or we can have not a long discussion, but I think a proposal. I think members have said about where they feel they may be. I'm not frightened of saying that you've heard my questions. I'm quite concerned. I think Lee and Mark know that as well, because I have some serious concerns following my questions. However, we are a democratic committee here this evening, and we have two recommendations on the table. Michael, have you got that on yours, or do you want me to? I mean, you've got your first recommendation on page 7. The committee is requested to consider the proposals from the Integrated Care Board and decide whether these proposals at this point in time constitute a substantial variation or development in the provision of health services in Medway. In the event the committee decides the proposals are not as substantial, which is the second one, if obviously we feel they're not, we will be able to request that the ICB bring to the committee any proposal which they have under consideration for a substantial development or a variation in provision of health services in Medway as soon as possible. Councillor Crozier?
Yeah, I think you've hit the nub there when you said at this moment in time, and that begs the question is, I mean, it clearly isn't a substantial change at this moment in time, but it may be a substantial change further down the road. So what kind of period what can we do in the interim period? How can we monitor that?
I think, Councillor Crozier, the issue, and sorry, Lee, you don't have to come back in it, because I think as a committee, each member will vote. We'll decide whether it's you're saying it in your opinion it's not. Members will make a decision on whether they feel it is tonight or not. You may have members that decide it is a substantial variation, members decide it isn't. And I suppose it's where we go, depending on where people vote and where they put their decision tonight.
Just to make the point, you clearly said at this moment in time.
No, I'm reading the recommendation.
Yeah, well, the recommendation is at this moment in time.
If we don't decide,
yeah.
Then it goes into the second part. But the first part is this a substantial recommendation?
At
yes
this
or no?
moment in time?
Yes or no? And that's for the committee to make a decision this evening on. Any member want to put a proposal forward? Councillor Wilding.
Well, to me, it is obviously a substantial variation because it is new contracts, possibly new providers, but even the same providers would be working to a different contract, may decide to work from different locations. To all of those make it a substantial variation. They would be working in different ways. That's the whole point of transformation. Again, that's a substantial variation. Now, I don't believe anyone around the table would like to slow the process up. 2 years seems too long to slow it down. I haven't been on any substantial variation when I was in your position that took 2 years. They took from 3 months to 6 months, and that did not stop the continuous work of the CCG as it was then, or even the PCT if you go back to them. All it would need to do is consult, which both Mike and Lee said they would be consulting all through next year. So that consultation, assuming it met certain standards, which I'm sure it would be part of our substantial variation. We would end up better informed, our officers would end up better informed, and not for our own sake. The reason to inform us is so that the general public are better informed. So I think it's got to be a substantial variation, and I think it's a red herring that it's going to slow the process down 2 years.
Thank you, Councillor Whitey. And just for Councillor Crozier's point of view again, you was right, about the substantial variation, and for members, it is a substantial variation or a development in the provision of health services, a development of what could be happening in the provision of health services. So just for that.
Chair,
just for
I think you misunderstand what I'm saying. I'm not agreeing that it isn't going to be a substantial change, but you did say at this moment in time, and it clearly won't be a substantial change for the next 12 months.
Yeah. Councillor Crozier, I think I'm reading the recommendation of the wording from the recommendation, and the committee decide whether they go with that first part of the recommendation. If they don't, they go with the second part. So I'm just reading what the wording is on there. So, okay, Councillor Hamadishi.
Thank you for that. Just for further clarification, when you talk about these contract terms, you said 8 years with additional 5 years extension. Is that across the board in terms of service providers? Is that across the board?
So it's a 5 years and a potential of a 3-year extension. That's a normal contract. Thank you.
No, thank you for that. It's a 5-year plus a 3-year.
Yeah.
Okay, thank you.
I don't want to open up too much. If Councillor Campbell, you can come back very quickly if you want. Go on, come back if it's just something a bit of clarity.
I think it's Councillor Wildey what he said, and I'm thinking that. I'm just unclear why, if we say it's a substantial variation, why would it turn from a few months into 2 years? I know you briefly mentioned that, but is there no way around that? Is there?
Councillor Campbell is a very, very good point. But I think I can make that I can, as chair, I can tell the committee that the committee are not held to, and I know Lee and Mark were not doing that, the committee are not held to ransom here by people telling us it's going to take a lot longer, etc., etc. We're here to make sure that service provision is done in the right way, and service and also procurement is done in the right way for our residents in Medway, and of course the rest of Kent, but Medway is our focus. So, it's true what Councillor Wiley was saying, and I'm not saying, Lee, that what you're saying about 2 years is untrue. That's not our responsibility about whether they're doing a fast procurement process or it's going to take longer. we've got to decide whether what they're proposing, what the ICB are proposing, is right and proper for our residents at this moment in time. I think that makes it a lot easier. It might make it a lot easier for Liam, rather than Liam Mark answering that. They weren't holding us to ransom, and nor would we be when it comes to this. Okay, so Councillor Wiley is saying about. I think I'll go. I think you know where I am on this, so I'm following Councillor Wiley. I'm proposing that as well, that this is a substantial variation. What we will do though, we will go to the vote, and members can vote. Michael, we'll go to the vote, and members will, with the Vice Chair, and we'll see who votes for what proposal, and that's what we need to do this evening. So it's recommendation, the first recommendation, and whether it's won or lost.
The committee is requested to consider the proposal for the Integrated Care Board and decide whether these proposals at this point in time constitute a substantial variation or development in the provision of health services in Medway.
So that's the... Thank you very much, Vice Chair. That's the recommendation on the table.
The proposal is that it is a substantial.
Yeah, the proposal on the table from Councillor Strucker from the Vice Chair is that it is a substantial variation or development in health service. Is that proposed and seconded? I propose it, seconded? Is that agreed? Do we have a vote on that? Can we have hands up? Can we have a hands up in case? Yeah, we'll do a hands up and do a count on that, if that's okay. Chair, Vice Chair, sorry. It is yours. I took it to make it easier. Come on. It's yours.
So that's passed then.
Is that agreed? All members happy with that? Okay. Thank you so much, Lee, and thank you, Mark, for attending. Obviously, we'll be in touch because you now know what happens with that now with regards to what we would expect from the ICB going forward. Thank you. Thank you very much. Members, thank you so much for this evening. I know it was a special one. I know you've got another one coming up shortly, but thank you so much for giving your time and for putting out good questions this evening. I know it's a difficult meeting, but thank you. Good night, everyone. Take care.
Thank you.